Hello, everyone. My name is Jaime Sepulveda, and I'm the Executive Director of the Institute for Global Health Sciences at UCSF. Today, as part of our COVID-19 series, we have a great topic, which is vaccine distribution and allocation. Who goes first and why? And we have first a presentator from UCSF Health, and we have a commentator from UC Berkeley. Dr. Desi Kotis is the Chief Pharmacy Executive for UCSF Health System, and she's also Associated Dean for UCSF School of Pharmacy. And she's in charge of, with others, of vaccine distribution at UCSF when we get there. Dr. Kotis is the recipient of many awards, including the Pharmacist of the Year Award from the Illinois Council of Health System of Pharmacists. And she also serves as Vice Chair of the Illinois State Board of Pharmacy. We will have as a commentator Dr. Stefano Bertozzi. Dr. Bertozzi is Dean Emeritus and Professor of Health Policy and Management at the UC Berkeley School of Public Health. He has been working on COVID, in HIV. Before, he was head of the HIV and tuberculosis at the Bill and Melinda Gates Foundation. He worked in Mexico for many years at the Institute of Public Health, and a real expert in public health issues. So we have a great panel, and I would like to ask Dr. Kotis to get started with her presentation on vaccine distribution. Dr. Kotis, you have the floor.
Thank you so much. Just share my screen. Okay, well, good afternoon, everybody. I'm thrilled to be here. As Jaime suggested, I am new to California. Almost been here 7 months. I grew up and was born in Chicago, Illinois, spent my entire career at Northwestern. So it's really a pleasure to be at UCSF Health during this very, very historical time and very exciting time, especially with the EUA meeting with the FDA and vaccines coming out within the week. So one of the things I wanted to review is what are we doing as far as all of University of California. UCOP, we've been meeting weekly. There's a whole group meeting from a bioethics standpoint, from an equity standpoint, from an operational standpoint, from an evidence-based clinical staff point. And we do have a draft policy that is a system-wide policy for all of our UC family, staff, students, trainees, as far as consenting to receive the vaccine. We are not making at this point the vaccine mandatory. There is an opt-out, and there will be a way to consent to receive the vaccine. At UCSF, I received an email in mid-October from the Department of Public Health if we were interested in being one of 7, it ended up 7 approved sites around California to receive early supply of the Pfizer vaccine. And again, we discussed that as a leadership team and decided it was the right thing to do for San Francisco and, of course, at UCSF. So we were pre-approved. We're one of 7 sites. There's another site in San Francisco, the Zuckerberg San Francisco General Hospital, There's another UC site. UC Davis is also in this grouping. And so as you can see here on this slide, COVID Ready is really what we're enrolled in. This was all completed at the end of October. And obviously we're collaborating with the Department of Public Health very closely. This is only for the Pfizer vaccine, I may add. And again, as you probably know, things are moving at a very quick pace. You may know that Moderna's vaccine will be going before the FDA on December 17th for EUA. So a lot of really fun and exciting times for all of us here. So just to give you an overview on the two vaccines, they are a little more complicated than other vaccines we're used to administering. They're a 2-dose vaccine. You can see Pfizer's is 21 days apart, Moderna's is 28 days apart. They are not interchangeable. And the good news is, if let's say I'm getting the Pfizer vaccine and oops, I missed the 21 days, now I'm at 28 days, it is perfectly suitable for me to receive that second dose. The Pfizer vaccine comes in a box of 975 doses. They are 2 ml vials. It's a lyophilized powder. Each little 2 ml vial has 5 doses. We need to store Pfizer's vaccine in very ultra cold temperature at a minus 70 degrees Celsius freezer, and it's good for up to 6 months. We don't know as much about Moderna, except it's a minimum order of 100 doses, a little bit better stability at freezer temperature of minus 20 degrees Celsius up to 6 months. Now here comes the fun part, and I'll show you some photos in a bit. The shipper box for Pfizer, the actual box of 975 is a 9-inch by 9-inch by 2-inch box. So think of your favorite pizza, and that's about the size of a large or extra large pizza box that the 975 doses are in. So there are 5 of those boxes that come in a big shipper box that has 23 kilos of pelletized dry ice on it. So I never thought I would know so much about different types of dry ice. But again, you can actually store in the shipper box if you don't have the right freezer space. You just have to change the dry ice, which right now is very difficult to obtain, as you can imagine, every 5 days. Whereas Moderna, it is good in the refrigerator for up to 30 days. So once the Pfizer vaccine is out of the freezer, it could be defrosted either at room temperature or in a refrigerator. It is good in the refrigerator for up to 5 days, and it is only good at room temperature for 6 hours. So here you could see sort of what, receiving, we've not received doses, but this is a depiction from the Public Health Department, some of the things that I've already talked about. So in one box, it's almost 5,000 doses. Some other things that maybe I haven't talked about, we need to reconstitute the vaccine with a preservative-free normal saline. We also can either do a room temperature thaw or a refrigerated thaw, as I said. And again, we do have the right freezers to store these. There's a lot about security that we've really learned to make sure our supply chain is secure. From, I've been told that the Pfizer trucks will have police escorts, at least on the freeways. And then we are working with our police at UC to get the vaccine to a secure location. Obviously, we have this in a secure place with security cameras and locks. And we will be looking and treating this vaccine as if it was a controlled substance, like a controlled 2 substance. So every dose will be accounted for, and every, obviously, shipment and vial. So a lot has been coming out on supply chain security, especially since Britain started vaccinating yesterday. A lot of ancillary supplies will be coming with the vaccine. We've also been, because historically we're not sure if the supplies will arrive at the same time, we've worked with our supply chain management team to make sure that we have the proper items that we would need for administering. So not only administering, but reconstituting. We also have proper labeling because of the stability of the Pfizer drug, but you're making sure we have all of the equipment that we need to operationalize mass vaccination. So this was something out of San Francisco Department of Public Health a few weeks ago. So as you probably heard, this number from 1 million doses has gone up to 2.2 million, Governor Newsom's press conference last week. And this is supposedly to be delivered by the end of this calendar year. So this month, which we're almost in the middle of. I like this chart because it really shows you how the vaccine from Pfizer will be allocated and distributed. So for the federal government is working directly with federal entities. So the Veterans Administration, the Indian Health Service, the Department of Defense, any federal prisons will get drug directly from the federal government. We're really looking at 1A. So, you know, there are tiers 1 through 4. 4 is everybody. 1A is the healthcare workers at highest risk, long-term care facility workers and residents. So 1B is the next level. So that also includes any high-risk workers or first responders that weren't treated in 1A, but it also includes high-risk patients, those with comorbidities. And so the federal government signed contracts with CVS and Walgreens, the big chain pharmacies, and they will be contracted for long-term care residents, skilled nursing facility, residential care, assisted living residents, those who may not have been in the 1A grouping and vaccinated. And then for the state of California, that's all directed by California Department of Public Health. They will make sure that state hospitals and prisons get supply. And then there's something called the MCE, or the multi-county entity. And to be a multi-county entity, the organization would have to at least have 3 counties where they would be responsible for. And those are maybe not your own employees, your own patients, they could be other patients as well. So right now, we're not in this multi-county entity yet, but it is something that we are entertaining as a UC right now. I know this slide says it's a TBD, but actually that work did start this morning. So again, we are getting quite a bit of guidance from the Department of Public Health. So let's say we do get our shipment next week, we will not start immunizing until DPH gives us the go-ahead. We also have to, as I said, document each dose like it is a controlled substance. We have to submit to Department of Public Health and the CDC every 24 hours the number of vaccinations, number of doses that we've administered in the previous 24 hours. We are utilizing a group with analytics, so we'll be able to show analytics of vaccination. And then you could see that local healthcare facilities from San Francisco Department of Public Health will be other hospitals. Again, those, as I said earlier, that are pre-positioned that will be receiving early allocation of vaccine in San Francisco, or UCSF and Zuckerberg San Francisco General. To note, we are looking at everybody at UCSF, so not just our care workers, but our researchers, our students, our trainees, like our residents and fellows, our faculty, our Oakland Children's Hospital, the Benhoff Children's Hospital is included here. We're looking at all of our affiliates, like those in Walnut Creek and Fresno. And again, I'm not being all inclusive, I'm just giving examples. So a lot to coordinate. We've been meeting for several weeks now, and now have broken into several groups that I'll talk about in a couple of minutes. I'm sure you've all seen this from the National Academy of Medicine. This again are the 4 phases. So since then, some of those in phase 1B were moved up last week to phase 1A, and those are those living or working in long-term care, skilled nursing, or residential housing because of their high risk. So really 1A is the highest risk healthcare workers. And again, this could be environmental service worker, a facilities worker, a transporter, a respiratory therapist, a pharmacist. It's not just a physician and a nurse. So that's 1A. Also first responders like our police force at UC are in that 1A group. So again, high risk for prolonged exposure, repeated exposure with COVID positive patients, or those with unknown COVID testing. And then 1B actually is all ages with comorbid conditions at high risk, older adults in congregate settings. And then you could see phase 2 goes into other workers like teachers and other critical workers, homeless shelters, and then you can see young adults, children in phase 3, workers in other industries, and then phase 4 is everybody else. So as I said, here from the ACIP meeting, this was at the end of October, there's one thing that changed, which I mentioned earlier, is long-term care facilities, SNFs, and residential living, who are now both residents and workers in the 1A group. So our highest population that is at risk is in 1A. Then 1B is next, as I talked about, and then phase 2, and then you could see 3 and 4. So it just really is dependent on how much vaccine we receive as to how quickly we could do this. I'm very optimistic that if we get what the governor is projecting, we should be able to get towards 1B this month in December. So that is extremely encouraging for us. Again, we just need to wait and see, because obviously we have an EUA on the 10th for Pfizer's vaccine, and then for Moderna's on the 17th. So as I stated, we've been planning with a lot of folks. Again, you know this takes a village. So it's the Department of Public Health, Zuckerberg, UCOP. We've had a very robust steering committee with our chief medical officers, with our population health leaders, our occupational health leaders. We've got people from communications. We've got folks from I think you guys call it the campus side, the faculty side. We have equity experts, ethicists involved. And actually, I know this says our draft was completed by the end of last week. Today actually is the 8th, and this afternoon, right after this meeting, we will be presenting our final draft for final approval to the chancellor. Here is the definition of a healthcare professional or healthcare worker. And again, I think I talked a little bit about this. We are looking at anyone in direct patient care with a risk of body fluid or aerosols exposures. And again, I've put some examples here with patient transport, environmental services, facilities, phlebotomists, you name it. We've talked about it in our group. So these are the 4 groups that we have made in 1A, because again, we started this weeks ago and we didn't know if we were going to get just a super small amount of drug in the pre-positioning phase or a whole lot of drugs. So really had to prepare for both. So you could see group 1 of 1A is frontline patient-facing clinical staff, as I said, with close, prolonged, and repeated exposure to either patients with COVID-19 or those with unknown COVID status. And again, we're looking at students on clinical rotations, faculty, our house staff, our residents and fellows, and then non-healthcare workers like our first responders, our police department. We're also looking at our researchers who are actively working with the COVID-19 virus. We are going to stagger vaccinations with groups of staff. So for example, if you're a nurse in the medical ICU, we're not going to have every nurse get vaccinated at the same time. We'll stagger it in either 25 to 30% increments within days, because the vaccine does have some effects. They're mild. They're seen, I think, in about, and I think we'll probably talk about this with the panelists, in about 2% of those studied, and they're high fever, fatigue, headache, nausea, and body aches. So nothing that a good old-fashioned acetaminophen capsule or another antipyretic or a non-steroidal anti-inflammatory couldn't handle. So you could see how we looked at the groups, group 2 as high risk, group 3 is moderate risk, and group 4 is other risk. The draft has also been shown to many others, experts in infectious disease, infection prevention, and then chairs of the departments as well. So this is our structure, and most of this, I know it says they're launching soon for the middle section and the bottom section. Those have launched and they're all in progress. So again, some really interesting and I'd say state-of-the-art work with our IT and clinical informatics team, education for not only our UCSF family, our employees and our faculty and students, but also for patients. Communications and media have done a really great job. We've got a lot of FAQs, both for staff and for patients. We have started over the last now week and a half in operations, so both for employee vaccinations and for patient vaccinations. And now we're getting the 1B and 2 prioritization, which a big chunk of that is our patients started, is how we're going to, because we're not sure our allocations again. And then the steering committee that myself, Dr. Adrian Green, Bryn Boslin, and Bob Kosnick have been sort of the core group. That started some months ago and obviously has expanded to a village of all the people that are working and managing all of these groups to probably close to 100 leaders, both on the health side and the campus side. So that is all I have, and I will stop sharing my screen.
Thank you so much, Dr. Kotis, for a very clear and succinct presentation. I'm sure people have tons of questions for you. I can see already that in the Q&A, some great questions are being posed. I encourage people to submit your questions there. Before I turn to Dr. Bertozzi, I have one clarifying question for you, Desi, if I may.
Sure.
If I saw correctly, in one of your first slides, you mentioned 1 million doses for California in this first batch. We had heard previously from the Chancellor and others that the allocation was going to be in the first batch 375,000. So this 1 million is an increase number?
No, so thanks. I mean, I'll clarify. So the number is around 327 for all of California for next week. And we know about what we're going to get. We're going to get a small amount. And initially, the governor said we'll have 1 million by the end of December. Last week, he stated 2.2 million doses by the end of December. So I've asked the public health group. They are saying we'll get like another 700,000. So up with the 327, we'll get about 1 million in December. So I think the number is somewhere between 1 million and 2.2. There are about 2.2 in that 1A group when you look at all of first responders, healthcare workers, long-term care, etc. So again, it is a pretty large amount, but again, that's by the end of December. So it's somewhere between the 1 million total, which we feel pretty confident with, to the 2.2.
Oh, that's great news. Okay, Stefano, I'm sure you have a lot of comments and questions, and I also have some questions for you, Steph, if I may, later on. You're on mute. Thank you.
Thanks, Jaime. I mean, I'm looking at some of the questions in the Q&A, and I think that Desi is going to have to respond to most of those. But I just have to say, listening to Desi and thinking about this is just such an extraordinary example of where so many different ethical public health issues come to a head. And I've been working a lot recently with the California state prison system, which, as you can see in what Desi showed, is prioritized in the second wave because of congregate housing. But that doesn't consider a whole lot of subtlety that is in there. So for example, the largest facility in the California state prison system, the California Medical Facility, that is essentially a skilled nursing facility, is probably the largest nursing facility in the state. I can't imagine there's one on the outside that has 2,400 residents. So I certainly hope that settings in the prisons, for example, that look like skilled nursing facilities would be prioritized. But what I was most thinking about as Desi was speaking, it's a little bit like Jeopardy. You see the answer of what the prioritization list is, you wonder what the question was. And so here's the question that I wonder, and Jaime, I'm sure you have some thoughts about this, but if we're thinking about prioritizing people, we want to consider the likelihood that somebody will be infected, right? And presumably that's why we're putting at the very top people who work directly with people who have COVID. But even that one is fascinating, because does that mean that people who refuse to wear masks should have higher priority than people who religiously wear masks? Because they're at much higher likelihood of getting infected. So, I mean, I just toss that out just to show that it's even likelihood of being infected is not a simple question. The second question is, what is the likelihood that that person, if they get infected, will have severe disease or die? And the third one is, what's the likelihood that if that person is infected, they will go on to infect other people? Now, one of the fascinating things about these vaccines is that the primary endpoint is prevention of disease. It's only a secondary endpoint that is prevention of infection. But if we're going to consider the relative priority in terms of infecting others, obviously we want to have a better idea to what degree the vaccines prevent infection and therefore prevent transmission to others. I strongly suspect that they will have a dramatic effect there. But of course, if you're a company, you want to give your vaccine the best chance of licensure by choosing the easier one as your primary endpoint. But from a public health perspective, it'll be really important. And so the reason I mention that is because as we think about whom should we be prioritizing, to what degree do the existing, even within UCSF, consider the possibility of preventing transmission to others. And so, as you know, Jaime, I have an 89-year-old mother and a 96-year-old mother-in-law, both in congregate housing facilities. And much as I want them to get vaccinated, I think that it's more important for the workers of those institutions to be vaccinated before they are, because they're not allowing any visitors. The only way they can become infected is through the workers in those facilities. Anyway, I'll stop there, but I think Desi should answer some of the questions in the Q&A, but I'd love to debate some of this more, because I think there's so many fascinating issues.
I presume, Stefano, that your mother and your mother-in-law are not watching your statement here. They might disinherit you. But I think you're making a good point about whether people wearing masks religiously or those defying masking should receive the same prize. Along those lines, you might say, should people that have already been infected and had a symptomatic disease should be kept for a second priority and let those that have not been exposed to the virus go first? So those are exceedingly complicated questions. It has been decided, to my understanding, that we will not be testing for antibodies to people before vaccinating. So we won't be able to make that selection.
But Jaime, in the prisons, we actually have that information because we've been doing full population-based testing. So we know which 17,000 people have already experienced infection. And you ask a very important question. Not only should we deprioritize those people, but should we deprioritize facilities where a high proportion of people have already been infected? I mean,
yes.
That's a very interesting question. You could ask the same question about nursing homes.
Right. I want to introduce Kemi Amin. She will be helping us in selecting questions from the Q&A, but she and I will be kind of interchanging questions to make this a little more dynamic. I would ask Desi one first question regarding a comment that Stefano made. The aim of an ideal vaccine would be to prevent infection, reduce severity of disease, and third, interrupt transmission. We know about the first two. We don't know much about interrupting transmission, particularly on asymptomatic people. So I wonder if you have any thoughts on that one.
Yeah, I mean, I've been trying to type away as you and Stefan, we're discussing. Remember that EUA is not, we don't have the emergency use authorization yet, and the FDA has to release quite a bit of information for us to know more. The only data we have is what, for example, Pfizer or Moderna has shared. So it's all coming from the manufacturer. So that's why we have to obviously be cautious. I mean, these studies were done well. I'm not trying to go there, but I'm just saying that we need to look and sort of see. Now, again, once people do get that second vaccine in 3 weeks, 4 weeks, they're still going to have to mask and social distance and proper hand hygiene. All that will continue probably for, they're saying 8 weeks. So again, we don't know yet. I mean, so there's a lot of things we don't know. I can tell you, even though the vaccine is not going to be mandatory like our flu vaccine is for UC, I do think the benefit of the vaccine truly outweighs the risk. So I'm a big advocate. I do think, maybe Stefan would want to take a stab at answering, or you, Jaime, but that's kind of where I'm at right now. I mean, I think we really need to see once EUA occurs, once the data is released, we all need to, the experts, you all will need to analyze the data so we know where we're coming from, because we're only getting, a little bit of data. It's from the manufacturer. That's all we have right now.
And this is a question for both Desi and Stefano. We have seen in the news that in the UK, they have already started vaccinating with using the Pfizer vaccine. And they chose a different priority setting than in the US. So they seem to have focused on age groups, starting with the eldest. And they vaccinated already a 90-year-old woman. She was the first recipient. And I learned this morning that the second recipient, an 81-year-old man by the name of William Shakespeare, received the vaccine. So any comments on the different approaches? Our 1A and 1B is different from the priority setting that they decided to follow in the UK. Any comments on that?
Desi, do you want to go first?
You could go first, Stefan.
Well, Jaime, I think that it really is this balance between the likelihood of death versus the likelihood of preventing transmission. And getting that balance right is difficult in absence of having better empirical data. So let's just give it, just as an example. If you had, for my mother's nursing home, 20 doses, and there are 100 residents and 50 staff, then where should you use those doses? Well, you can make the case that if you vaccinate the staff, you're protecting all 100 residents. Well, if you vaccinate a part of the residents, you're still leaving the other residents exposed. So I think that, and that's a situation, a relatively simplistic situation. One of the things that, one of the Q&A questions was, will the vaccine be mandatory? And Desi responded that it wouldn't be. But what I've recommended to the prison system is that we cannot, I don't think that we can even legally oblige people to take a vaccine that is only under emergency use authorization. So in the UC system, for example, we're obliged to be vaccinated against influenza. I don't think that until the vaccine is fully licensed that we can oblige staff to be vaccinated. But that doesn't mean that we have to allow staff who have not been vaccinated, whether it's the prison system or in UC, to work in very high-risk environments, right? So it may be that if you choose not to be vaccinated, then you can't work with elderly patients or immunocompromised patients or whatever, because we want to make sure that we are protecting those patients, especially patients who, for whatever reason, either can't be vaccinated or in whom the vaccination is unlikely to be effective. So, I think that there are policy responses that are short of requiring vaccination. In the case of the prisons, for example, my recommendation was that guards who are not vaccinated, once the vaccine is available, should not be allowed to work in multiple housing units, because the guards that work in multiple housing units have the potential of spreading an outbreak from one housing unit to another and dramatically increasing the scale of an outbreak within a prison, just as an example.
Great. I'm aware of time, and I see a lot of questions coming in. Kemi will be selecting some of those. Kemi, would you go now?
Sure, yes. I have a question here that says, how will the vaccination be documented per individual / public, private record, and the ability to say, travel, and participate in social settings?
Yeah, so the vaccine will be documented in the health records. So the clinical informatics folks have done this amazing job of getting things ready. So it will also go in the Department of Public Health record. So those vaccines, very similar to other vaccines, can be located. And then we will be sending that feed to the CDC. So it's an electronic way of documenting the vaccine administration. As far as the second part, I mean, that's going to be the fun part, is we're all going to live through it, right? So again, you know, after that second dose, we will still have to keep our, you know, keep everybody safe by masking and hand washing and social distancing, at least for some months. So we'll know more as we get more and more people vaccinated.
But the other aspect of the question is really gets back to what we were, you know, what was referred to months ago as, quote, an immunity passport, right? If you've been previously infected, should you now be able to take off your mask and get priority for frontline positions in supermarkets or whatever? And that, of course, is going to be reactivated now with this discussion of, do I get an immunity passport when I'm vaccinated? And how long is it good for? And, you know, given what we don't know about duration of immunity, et cetera. I think it's a really interesting question. And it's related also to the other question that came up about why aren't we testing for antibodies? If what we're really trying to do is to use limited number of vaccine to have maximum benefit, is it worth it to do antibody tests? And I think part of the answer there has to do with the imperfect nature of our antibody tests, which would complicate this very significantly. I wonder, because I've heard that UCSF is going to use one dose very widely and only start applying second doses when there's sufficient availability of supply. And that's related to Robert Choi's question about whether there's any reason why providers can't choose to do that themselves, or whether they need FDA authorization to do that. And I suppose the related question there is that, is there any reason to be concerned about a second dose that's significantly later than the recommended timing to the second dose? What if it's 4 months instead of 21 days? Desi, I don't know if you want to take
Yeah, I mean, I know the one thing we've addressed is the exact date, you know, 21 or 28 day respectively on the two vaccines that will be going for EUA in the next, you know, this week and next week. You know, there could be a week or two. I'm not sure if, you know, you can do your second dose in 4 months. I don't, you know, we don't have that data yet until, you know, we get the FDA's release and we start looking at things. So I think we're going to have more. I mean, I know our PMT, our Pharmacy and Therapeutics Committee, also, depending on if more vaccines come out, we'll look at and evaluate all vaccines for safety and efficacy, and some of these very difficult to answer questions. But right now, you know, we're going to need to look at that in a little more detail. The CDC, ACIP, the various departments of public health do say that, you know, that you get your whatever, how many doses, you vaccinate everyone with the first dose. I mean, that's really what the evidence shows right now, and that there will be supply for that second dose in 3 to 4 weeks.
You know, go ahead. Sorry, I thought you were done. Sorry.
Go ahead.
Well, I was just going to say, if I put my economist hat on, let's say that first dose is 70% effective and both of them are 90% effective. You're only getting an additional 20% of effectiveness with that second dose. You'd be much better off getting a bunch more 70%ers vaccinated rather than adding 20% to the ones who are already vaccinated, unless they're at extremely high risk. So I think.
But I would say this is kind of an really hypothetical question. Interesting.
Yeah.
But we are relying on press releases by the pharmaceutical companies. We don't have yet peer-reviewed, published papers. So I think we can get into a lot of speculation. We could also speculate, well, what happens if we do heterologous priming? Heterologous priming is about using 2 different vaccines. Would that be better or worse? We don't know. So we can speculate a lot, but I think we have to stick to what the FDA approves and recommends, and keep it as straight as possible so that we don't make unintentional mistakes.
But Jaime, so it's not true that what I had heard yesterday was that UCSF was planning on doing much on using supplies to do the first vaccination until there was adequate supply, and then start second vaccinations. That's not true? UCSF is planning to vaccinate everybody with a second dose at approximately the recommended time?
Correct. That's right now all we have, and we have to go by that evidence. And that's the guidance from the health departments, from ACIP, from CDC, from many agencies.
Very good. No, I had heard the opposite, which is why I was asking.
Well, but be careful with conspiracy theories and fake news. No, the official stand is that we will follow the FDA and CDC recommendations. Okay, I see many questions coming. Kemi,
Yeah,
would you
I actually wanted to bring, Desi, you already answered a couple of versions of this question, but I wanted to bring it live as it refers to Black, Indigenous, people of color. Someone asked specifically, will there be prioritization of populations based on burden of disease and population vulnerability? If so, can you discuss the process of creating this prioritization framework?
Yeah, I mean, the slides showed the high-risk populations with respect, and I wanted to go back to Jaime's point about what Britain is doing with age. That's another thing, so age, zip code, and other items like, I think there was a question, Latinx and Indigenous and African American. So again, when we're looking at these things, we are looking at the data and what the evidence is. And I know from a California perspective, the governor's task force, the Department of Public Health for California have looked at age, they've looked at zip code, they've looked at race as well. So there's like who gets infected, who is at more risk to die. So again, all of those factors are being taken into account, and that's where the 1B to 4 groups are located. So if you saw that ACIP sort of guideline from the slide, I could put it back on if you guys want, but I know we're running short on time. But again, all of those factors, like we talked about earlier, the bioethics piece, the equity piece, are a very, very big part of decisions on the UCOP level. So once we get through the healthcare providers, I can tell you other states are not going through this. Some are doing just random for their 1A, like kind of a lottery system. Other folks are exclusively doing things by age. So again, the government or the Department of Public Health for each state is not dictating what to do. We are going by the evidence, and I think what we're doing and how we've put things into the 4 groups for 1A is the right thing to do. Looking at every worker that has highest exposure, every first responder, people that might not be clinicians but are transporting or are cleaning or are in rooms fixing things. I mean, we need to really look at the whole picture, including students who are on clinical rotations and researchers who are working actively with the vaccine. We're also looking at all of UCSF. And again, being new, only 7 months here, Fresno and Walnut Creek and other places, where there are UCSF employees.
I have a logistical question for you, Desi. We know that the Pfizer vaccine requires ultra cold temperature for preservation. What does it mean for low and middle income countries that might not have the capacity for storage, and getting ice might not be easy for many places, even in the US, as you pointed out. How do you think that issue can be solved? Do you think that the storage and transportation system is good enough in long distances and in countries that do not have the logistical and financial support?
Yeah, I mean, I'll start with the U.S. It's a challenge in the U.S. and rural populations, very, smaller communities, because you're right, I mean, pelletized dry ice and changing it out every 5 days is not very easy to do. So with Pfizer's vaccine, it will be more difficult, more of a challenge. It has to be reconstituted, thawed, reconstituted, then 5 doses in a vial versus a single dose vial or syringe. So a lot of logistics. And I know here in the US, there are portable storage freezers. There's thoughts that, that one box of 4,800 doses, about that, could last for 5 days. You can actually vaccinate a whole lot of people just by that one box. So again, that's why we're working in California, because there are some areas that aren't densely populated that may need help. So that's why we are considering being a multi-county entity, so we can help those in, a little bit out there, because we do have those items. Now, when you look at other countries, again, I was involved in a project about a few years ago, drone delivery of blood in parts of Africa, vaccines, not this vaccine, but other vaccines in parts of Africa where the roads were impassable during rainstorms with drone delivery. So maternal hemorrhage after birth and getting blood there, or getting certain vaccines, getting antidotes with drone delivery. So, I mean, again, how will this be done in certain parts of the world will be definitely very, very tricky. And you can't interchange these vaccines. So you have to stick with one or the other, at least the two that are coming out, the mRNA vaccines soon. So there are others, they're a little delayed. So again, it'll be interesting to hear Stefan's ideas with, what to do. Do people wait where there's a vaccine that, maybe a little easier, more portable, more stable? But yeah, there's some very huge dilemmas, even in our country here.
Stefano?
I would just say that, fortunately, the more widely dispersed the population, the lower the risk of explosive, massive, super spreading type outbreaks. And even in developing countries, large cities have dry ice capacity. And to the extent that flights can come in and, the vaccine doesn't have to be stored for a long period of time, I'm hopeful that even with all the problems that Jaime has mentioned, while you were talking, Desi, I was Googling how many dry ice suppliers are there in Lagos in Nigeria. There are lots. So I think that the amount of dry ice needed to keep such a very small volume cold is within reach in many, many countries, even if they don't have a lot of -70 freezers. So I'm just choosing to look at the glass half full side of that. And hopefully that can at least mean that we don't completely shut out the developing world, even for these first vaccines that are authorized. And I think it's really important that the highest risk people everywhere receive vaccination. But, interestingly, to what degree are we prioritizing places that have extremely high incidence over places that have lower incidence? Should Kansas or South Dakota have greater priority than California because their epidemic is more out of control than ours is? And what does that mean at a global level? At a very micro level within the prisons, for example, do we prioritize the prisons with outbreaks, or do we prioritize the prisons at greatest risk of outbreaks? We know that if we start vaccinating today, that people won't be immune for a while. So if we're in the middle of one of these huge surges in a particular facility, these are difficult questions when we have very limited supplies.
I wanted to ask, giving time to Kemi to select the next question. Desi, Stefano, are you familiar with the COVAX system in Geneva, an alliance of WHO and Gavi and CEPI? Are you familiar with what they are planning to do in terms of distribution to low and middle income countries?
I mean, I suspect that you're the best person to answer that question. I'm somewhat familiar, but I think that you're probably more familiar. Why don't you start and let us add on?
So COVAX is a mechanism created at WHO with Gavi and CEPI with support from the Gates Foundation. And the idea is that there will be some kind of an equitable access allocation of vaccines to countries. Pfizer has been part of that, AstraZeneca, and many other vaccine manufacturers that are in phase 3. But what I would not like to see is that we have vaccines that are of less quality in terms of efficacy being distributed to low and middle income countries, while the most successful vaccines are not. So there might be a problem of overflow with having too many vaccines being offered, and how to decide which goes where, I think is going to be an ethical problem as well.
I think you're right, Jaime. What is a bit fascinating is that usually incidence of an infectious disease is pretty strongly correlated with poverty. And in this country, it is strongly correlated. But globally, it's not strongly correlated. So the question of what does that do to vaccine distribution prioritization is I was hoping you were going to shed some light on that, because I've seen that those efforts so far are mostly about reserving production capacity and therefore supplies for low and middle income countries. I haven't seen the detailed prioritization, whatever the supply is that we're able to reserve for low and middle income countries that have not been able to purchase directly. Then how are we going to distribute those vaccines, and what is the prioritization going to be among countries? I'm assuming that within each country will make that decision. The
Yes.
WHO and the initiative will be responsible for saying, you know, how much more should Nigeria get compared to Tanzania? And is that just a question of population, or is it also a question of what the epidemic curve is in those two countries? Relative urbanization or other sorts of factors.
Yeah, WHO has two priority setting, one based on population, which doesn't make sense because China might not need it. The other one is on population over 65 and the burden of disease. So both have some complexities from the ethical standpoint. But Kemi, we're about to close in 3 minutes. Do you want to pose a question?
Yeah, there have been a couple of questions around testing. So antibody testing, testing in general, at-home tests have been a big thing about having those available with vaccination as a way to get towards post-COVID. What are your thoughts around that? Do you feel like testing is a big part of this process as well?
I'll let Jaime or Stefano answer those questions.
Well, I was fascinated because yesterday my future son-in-law came home and said that he has never received a chickenpox vaccine, and the physician said that he shouldn't get it until he's tested for antibodies. And I thought to myself, how interesting to juxtapose that with the current recommendation that we not test people for antibodies for a vaccine where we're desperate for greater supply. So it seems to me that, I mean, obviously the biology may also be different, but I don't know the degree to which the vaccine has been tested in people who were previously infected. So it may even be that it's wiser to not vaccinate people who've been previously infected until we have that information. It also may be that that way we could save the vaccine for people who have not been previously infected. But then the flip side of it is that since a relatively small proportion of the population has been previously infected, it may not be worth it. And it may be, you know, the time and energy and expense of testing people may just not be worth it. I tend to think the latter is the case, but I think the people who've been asking those questions are asking very relevant questions that a little bit of modeling should be done to help address.
Okay, well, we have reached the time. Dr. Kotis has been answering a lot of the questions. Thank you for doing that while we talked, and there are only 4 left. We will try to answer them subsequently. This is going to be our last COVID series of the Institute for Global Health Sciences in this horrendous year of 2020. I'm very optimistic about 2021 with new vaccines coming, with a new administration, and certainly with many interesting COVID series yet to come. So my best wishes for the holidays and stay safe. Thank you all. Desi, Stefano, Kemi, thank you very much.
Thank you, Jaime, Kemi, Desi.
Thank you.